Who is she?
She's my girlfriend.
You trust her?
More than myself. Come on, let's finish.
Dr. Mishra? Dr. Mishra? Dear Dr. Mishra? Dr. Mishra? Yeah. Dr. Mishra? I see your slide. Open your video.
Okay, now
Yeah,
finished.
very good.
Okay, can you hear me now?
Yeah, I hear you, but not see you. Please open your video, your camera.
I don't know, hi, my friend, this one.
Okay, dear friend. Okay.
Okay, open file. Should I put the open file or what do I do?
The file is very good.
Open
need
file
your
on the bottom.
Yeah, need your camera.
But see, I don't see that stupid video. Hold on a second. Sharp, your screen. Okay, hold on a second.
Yeah.
Oh, okay, okay.
Very good.
No,
Okay.
no, it took,
Yeah, very good. Hi. How are you?
Oh man, I tell you, this is more confusion.
Okay, all we use these applications for any presentation today.
I know, but I have no idea why this takes so much time. Okay, are you guys there? Everybody there?
I'm happy. I'm happy to see you. Just to introduce you, and let's start. A lot of audience need to listen from you.
Okay.
Just I'm sorry for this. Some
I
technical.
know, man. Yeah, every time. So we have to figure it out because I don't have any problem with the other Zooms.
Oh.
Okay, let me start here. Can you guys
Yeah,
hear now, everybody?
Please, just I will introduce you at first, please. Okay. For all attendees, thanks for joining us on this episode today with one of the eminent figure in neuromuscular junction pathology. He is the Professor Cherry Mishra, who is a professor of neurology, Keck School of Medicine, and also director of neuromuscular program, David Jeffin School of Medicine. He is one of the best. He joining us in past year in previous conference, and he's almost attract all the attendees for his very useful and informative talk. So today we will speak about an overview of the neuromuscular disorders. So the screen with you, dear Dr. Mishra. You can start now. Okay.
Okay, listen, I'd like to thank all of you, those who are there. I mean, again, Najam and I have worked very closely. And then, of course, for so many times. I'm going to talk to you about neuromuscular junction and spend more time on myasthenia gravis. So, I know I'm just trying to get why I'm not getting.
Very good.
I know I see that, but then why?
But need to enlarge it. Yeah.
Okay, hold on a second.
Okay.
Okay, the guy. All right. So one of my interest is history of neurosciences and neurology. You know, this is a picture of 1644. It's called Pocahontas, which is an American Indian who was in Virginia, part of eastern United States, and the Britishers were already have taken over the, the America. So he had some kind of symptoms which sounded like myasthenia gravis, and he was taken to London, and they didn't know what to do. But anyway, but then German neurologist Wilhelm Erpoint, he described 3 patients, those who had symptoms like myasthenia gravis, and they wrote a paper, droopy eyelid, difficulty in chewing, etc. So that's kind of history, and there is more to it, but so the basic structure of neuromuscular junction, if you all recall, I had given you in my last slide. I talked about, like spinal cord. Then we have, like nerve. Then I have described by neuromuscular junction and muscle. So I'm focusing on neuromuscular junction. And neuromuscular junction has 3 parts. Can you all hear me?
Yeah, I hear you.
Okay, good. So one is presynaptic, and the other one is synaptic, and I'll show you the pictures. And the third one is postsynaptic. So back again here. So this is again, like the nerve coming out, and here is the presynaptic area. You got mitochondria, you got acetylcholine receptors, and from there you have, like postsynaptic area here, and you got a skeletal muscle fiber. And so there are acetylcholine receptors, which is very important. We didn't know that before, but we knew very closely what happened to the acetylcholine receptors. And that's abnormal in both presynaptic and postsynaptic disorders. So there are just many things happen. Okay, the acetylcholine synaptic vesicles, which I showed you earlier, it has 3, one is called snare complex, which takes, VMPs and this one, and the vesicle then fuses with the neural membrane and empty their acetylcholine into the synaptic space by process of exocytosis. So this is a vesicle fusion, and it binds the acetylcholine receptors and the muscle fibers, and you have excitation, contraction, coupling, means muscle contraction. So here are these things, the vesicles, the dock, the fuse, and then there are many processes here. Calcium is involved, calmazolin is involved. And so back again, that's a presynaptic area, then synaptic. And in synaptic area, you have acetate and choline. So acetylcholine, which is acetylcholine receptors, which kill by this acetylcholinesterase here, okay? And after when it's killed, then there's more acetylcholine is available. Like we have talked about myasthenia gravis, and we'll tell you that this mestinon, which blocks this acetylcholinesterase and divide into the choline and acetate from here, and then it transport back to presynaptic area, but further, growth. So here is a postsynaptic, and here are the normal, acetylcholine on the peak here, acetylcholine receptors. Okay, this is electron microscopy located in the peaks of the folds here. And you remember myasthenia gravis, you will have a damage of this area, and so do, like Lambert-Eaton syndrome. So here is a summary, what I have talked to you. So here is coming the nerve, terminal axon, and then of course, you have basically a vesicle acetylcholine. You got voltage-gated sodium channels over here, plasma membrane, and then the gated channels. So if you look at here, these are all open up, and earlier, the pictures I showed you earlier is a little bit more bigger picture. So acetylcholine receptors are very important. And these are gated ion channels, and their molecular weight is 275,000. And you have many types of, the acetylcholine receptors. Alpha, then you have beta, delta, and gamma. And these are all there, and I'll tell you more later on what is the function of that. So I want you to remember, so this is the same thing as still, like here, and you got, like 2 subunits of acetylcholine binding site. We have fetal units, gamma units, and then, here, this gamma replaces the fetal subunit. In the pediatric age group, you have this gamma, but adult, you see here, A, B, C, D, and here is the like you were showing this empty segment, the closed gate. This is a gate, open and closed gate. And basic thing is that there are a lot of receptors, which I want you guys to remember. They have agrin, which is another compound, raspin, musk. Sometimes we do see musk associated, like muscle specific kinase associated receptors. So you would do sometimes it's called musk myasthenia gravis, and I'll talk more about. And there are a lot of this over here. They all have been described to produce neuromuscular junction disorder. All right. So back again, we have antibodies in myasthenia gravis. I just want you to remember. And you have a basic thing is that acetylcholine receptors, we already talked about. Then you have also other receptors, which here are important, like this LRP4, okay, which is a rare, but it can be associated with, there are 1% of patients who have LRP4 myasthenia gravis. Then you have, like a respin located over here, and acetylcholine receptors are here where I talked. That's the main one, acetylcholine receptors. Then you have a musk, and then you have an agrine, LP4, and all of them. So they all can produce myasthenia gravis type syndrome. Okay, so back again, here you saw earlier, you have acetylcholine receptors, and then you have, these are musk, like receptors. And that is not very common, but you can see it. So I guess I'm already I've talked to you. The neuromuscular junction, acetylcholine, okay, receptors are synthesized in presynaptic areas. And from there, it comes out to vesicle docking, which I showed to you earlier, and vesicle fusion at the postsynaptic receptor, and can cause muscle and receptors on motor end plate and can. Okay, so that's kind of basic thing. You guys are there? Are you hearing me? Megan? Okay. Okay, all right, I see that. So neuromuscular junction is 3 types disorders: presynaptic, synaptic, and postsynaptic. Okay, you guys okay? Are you hearing me? So, are you hearing me? You are sharing a screen, so that's okay. So neuromuscular junction, we have a presynaptic disorders, you have postsynaptic disorders. Okay. Nigam, are you hearing me? Are you hearing me? Okay, well, I'm not mute. I'm sharing. Participants are 11. Okay.
Yeah,
so
yeah, I
please,
hear you. Yeah.
Okay, good. So
Good.
you
Yeah.
keep it, okay, keep yourself. So I just remember
Okay.
last time. So we have 2 groups of neuromuscular junction disorder. Presynaptic, as I have described to you, and postsynaptic is more important for myasthenia gravis. So the presynaptic, people are born, it's called congenital presynaptic disorders, like Lambert-Eaton type, but they are born with it. And then you have also person with congenital Lambert-Eaton syndrome. They are born with this. They are not associated with cancer. And then you have acquired limbs, which is mostly associated with the cancer here, but it could also be, the congenital, the limbs without cancer, okay, acquired. And then you see botulinum toxins, which is the one area where we do see. And then you have postsynaptic disorder, which is a congenital. We have congenital myasthenic syndrome, and there are many of them. And they are not immune mediated. I just want you to know. Then you have acquired, which is myasthenia gravis. So Lambert-Eaton syndrome, which was described at Mayo Clinic by Dr. Rook, Eaton, and Lambert, and I happened to work with all 3 of them when I was at Mayo Clinic. And basically, the more male are more than the females for limbs are Lambert-Eaton syndrome. and their age can be 17 to 75. The one important thing with limbs that you don't have ocular weakness. Okay, the weakness is mostly arm and legs, more distal. So back again, you can also have sensory neuropathy, because you have, and then you have dry mouth, and you have impotence, and the tendon reflexes are decreased. And again, there are many drugs which can block myasthenia gravis as well as Lambert-Eaton, particularly antibiotics, fluoroquinolone, magnesium, and aminoglycoside. So if you are having somebody presynaptic like Lambert-Eaton or myasthenia gravis, do not use this antibiotic because they can get worsened. Okay, so there are others too, calcium channel blocker. So the types of LEMS, as I mentioned to you, congenital, associated with, myasthenic syndrome, associated with a neoplasm. And here are the things. If I'm doing rotating nerve stimulation, this is a kind of normal, but the second one is decreased, and after exercise it increases. Same thing with myasthenia gravis, but Dr. Lambert, I'll show you the picture later on. This is a 10 hertz per second, but he did 30 to 40 hertz per second. That was Dr. Lambert first when he described this. Okay, so again, increment, and that's, after stimulation, after exercise, it goes 50 to 100. And most is specific for limbs, okay, when you stimulate. Okay, so 50 to 60% of the patients with the limbs, they have tumors, lung tumor, you have reticulum cell sarcoma, you have T cells leukemia, lymphoma, and etc. Prostate, important. Okay, so back again, we already talked about, always when you see somebody, you always get the chest X-ray, actually CT scan, and you can do PET scan maybe if needed. Okay, then other group are without cancer. They are like Lambert-Eaton in every way, distal involvement, sensory problem, autonomic neural, and these people, they have, anti-PQ, BGC antibody titers in the limbs, but without neoplasm, you don't have that much there. And increment is like earlier I talked to you. And sometimes person have problem, this one before the cancer is detected. Okay, so I just want you to know. And then the treatment is steroid or other immunosuppressive therapy, and I'll tell you more about it. Other treatment. So this is with neoplasm. You have dysphagia. You do have problem with the extraocular muscle are not involved. Symmetric autonomic neuropathy, dry out mouth, and impotence, and deep tendon reflexes are decreased. That's not the case in myasthenia gravis. So treatment for all myasthenia, after myasthenic, like Lambert-Eaton syndrome, is this particular. It's called 3,4-diaminopyridine. It's also called Firidex. Was recently, basically FDA approved for them, so it became very expensive. And you can use Mestinon, and then you can do other immunosuppressive compound like plasma exchange, IVIG, and rituximab. And then, of course, treatment of the cancer, of the neoplasm. You will take out the neoplasm, and patients do get a little better. Okay, so that's a Lambert-Eaton syndrome. Lambert-Eaton syndrome used to be called before Eaton-Lambert syndrome. The Lambert-Eaton syndrome, which is a presynaptic disorder, is due to basically non-cancerous and cancerous. Okay, so the next one is botulinum toxin. And botulinum toxin, I know you guys see there, we very rarely see here in America, but I've seen a lot of them in India. So foodborne botulinum toxin, particularly people living in high altitude, and they're getting that, soup, etc. They don't warm properly because high altitude, it's less, and wound botulinum, we have a lot of patients with wound botulinum. and the iatrogenic botulinum and inhalation, but mostly we do see foodborne and infant botulinum. Infant botulinum is due to honey. So you do not give babies honey till 1 year of age, because they could get the botulinum toxin carried out by honey. So this is, again, the important thing is that they have extraocular muscle weakness. They do have difficulty in swallowing. Tendon reflexes are reduced, and they have dilated pupil. I just want you to remember that. It's very, very important. See here, whereas myasthenia gravis, Lambert-Eaton syndrome, this one here, the pupils are not dilated. Okay, and there you have bradycardia, etc., and constipation. So the treatment part, diagnosis is the same thing, repetitive nerve stimulation, as I showed earlier. Now this is again is from the Lambert-Eaton, and this is very high frequency. You're giving 40 hertz per second. You see here, it went 500% increase. We don't use this; it's very painful. But Dr. Lambert did the first, but for Lambert-Eaton, as well as he did it, like for patient with botulinum toxin. And the treatment of botulinum toxin is antitoxin, depends on what kind of the botulinum toxin person is affected. And then you intubate person and then give antibiotic, etc. So that's a kind of finished my presynaptic disorders. Okay, so back again, postsynaptic disorders is most likely myasthenia gravis, which is the main talk, my major talk, and it's a pretty, like 15 to 120 cases per million. The annual incidence is 1 to 300,000. And important thing is over here, there are bimodal pattern. Okay, early age, second to third decade, female predominance. After age 50s, 60 to 70, they have more male predominance. And basically you have ocular myasthenia gravis, which is ptosis, and then, like diplopia and weakness of bulbar muscles, etc. And the aggravating factor, as I had mentioned to you, the antibiotic medication, which I talked to you, pregnancy can worsen the myasthenia. Already person has myasthenia gravis, they get worse. Emotional stress and thyroid disorder and infections. Okay, so back again, anti-acetylcholine receptors, autoantibodies impair the signaling by 3 mechanisms. One is complement-mediated damage, and we'll talk more about it later on. Complement, and functional blockade, anti-acetylcholine receptors, autoantibodies prevent acetylcholine binding, and then antigenic modulation. Autoantibodies cross-link acetylcholine receptor, stimulating internalization and receptor degradation. So antigenic modulation. So main thing I just want you guys to know about complement-mediated damage, which we didn't know before. So back again here is a muscle, and here is a action potential, calcium, acetylcholine is coming out. I just talked to you earlier. Comes out here, sodium causing muscle contractor. And here are the different things. Acetylcholine receptors, I had mentioned to you earlier, MuSK, LPR, and this all abnormalities. The person gets, let's say abnormal. So remember this, thymoma is associated, I'll talk more about it, 10% of the myasthenia gravis, but adult and young age group, they have thymoma. And 60% of the patients, they have thymic hyperplasia. So if you look at here is the complement activation. So back again, complement. And most important thing is here coming out and blocking antibodies. Okay, that's like the C5, C9. Okay, so you got it. So this is again blocking antibodies as to and others here, but then you do have this the complement, this C3 complement, which is blocking the acetylcholine receptors, and therefore you develop myasthenia gravis. And there's a new treatment, which I'll tell you more about it. Okay, so back again, myasthenia gravis is neonatal form in the sense that baby is 10% of the babies born with the mothers with myasthenia gravis, they have neonatal myasthenia gravis. And it's a self-limiting process. You know, usually they get better in 2 or 3 days because of the transplacental passage of maternal acetylcholine receptors antibodies. It passed through the placenta. But they get better in 2 or 3 days. You may have to intubate. And then you have congenital myasthenic syndrome. There are a whole bunch of them. And this one I may describe you guys later. And then this one here, autoimmune myasthenia gravis, is most common. Okay, so back again, I mentioned to you myasthenia gravis is ocular myasthenia gravis and generalized myasthenia gravis in all age group. Ocular myasthenia gravis, ptosis and ophthalmoplegia. And if the person continued to have only ocular myasthenia gravis for 2 years, they didn't get bulbar symptoms, they didn't get weakness of the muscles, then usually they don't become generalized. Just remember that. And then again, you have acute onset, subacute onset. Usually patients tell you, the doc, I'm doing good in the morning, but afternoon, in the evening, I start seeing double. And it gets worse in the night. And then the other entities, I just want you to know that these are the symptoms can be worsened. Hot weather, okay? One of the tests which we do on ocular myasthenia using ice test, and the patient get better, their ptosis gets better. And here are aminoglycoside beta blockers I had mentioned to you guys earlier. And there are 2 other entities which you need to know. So ocular myasthenia, generalized myasthenia gravis, then myasthenic crisis. Myasthenic crisis is a neurological emergency. It's really bad. You have to use intubation, you have to give IVIG or plasmapheresis. And you can also have sometimes what's called cholinergic crisis, which like emergencies, like myasthenic crisis. Somebody taken a lot of mestinone, which is acetylcholinesterase inhibitor, taking a lot and they produce. Okay, here are the things you see: facial weakness. The guy had ptosis. This lady, remember, I will talk more about it. It's called snarl faces. Her face looks kind of like this. So this is a musk-associated myasthenia gravis. Very rare, but remember that. Okay, so back again, ocular myasthenia gravis, I already talked to you. And then, and then you have early onset myasthenia gravis, you have late onset. These are more females. Okay, early onset, you have thymic hyperplasia. You could have in both of them, you have thymoma, 10% to 15%. Okay, so back again, thymoma associated myasthenia gravis, usually you have later onset, and there are antibodies against the acetylcholine receptors. For thymoma, you do titin or voltage gated calcium channel. And we always, if I'm suspecting, I do this titin and musk antibodies. We don't use routinely. We just use it in cases who are not responding to the treatment and not doing well. And then you have a very small percentage of patients, they have seronegative myasthenia gravis. So diagnosis of myasthenia gravis is a clinical, as I mentioned to you. You think, is it ocular myasthenia gravis, generalized myasthenia gravis? Think about whether it's not associated with thymoma. And the test, what you do is 2 things. One, serological. That means the acetylcholine receptors antibodies. There are 3 of them: blocking, binding, and modulating. We all do 3 of them. Binding is most common, blocking is the second common, modulating is least common. Then you also do the thyroid function test. You do ANA because there is association of immune-mediated disorder with myasthenia gravis. And then you do, of course, chest X, CT, scan we always do, and then you do this electrodiagnostic test, electrorepetitive nerve stimulation, which I showed you earlier. Okay, so back again, as I mentioned to it, binding, blocking, and modulating. Okay, you always do it. Ice test. If somebody has ocular myasthenia gravis, take the ice and put it on the ptosis on the eye, and it gets better. We don't do any more tensilon tests in America, but this is another one. It's short acting. You give IV and the patients get better. We don't get it. The thing is, the next is electrodiagnostic test, which is a repetitive nerve stimulation. And the last one is single fiber EMG. And then I already talked about chest CT. And then you also do patients with generalized myasthenia gravis. You do the vital capacity, so you know exactly what's going on. So this is again repetitive nerve stimulation. So back again, what I'm doing here, I'm recording from the ADM muscle. And I think if many of you, those who were there in Egypt as well as Morocco, you saw me doing this. So you're stimulating here in myasthenia gravis, there's a decremental response. See here, this only do 2 to 3 hertz per second. And then, so here is a repetitive nerve stimulation. First you do distal muscle. And if, let's say if it's a negative, then you do accessory nerve and you record from trapezius. Rarely you do the facial nerve, okay? So here is a normal state, and patient with myasthenia gravis, see here, there's a decremental response. And ask the person to exercise for a minute, okay? And see here, basically, you know, like it gets corrected in myasthenia gravis. So this is again, rarely we do single fiber EMG. This is normal called jitter, an increased jitter in myasthenia gravis. It's a very, very selective though, but it takes 2-3 hours to do it. Okay, so single fiber EMG is a most sensitive test for myasthenia gravis. The only thing is it takes a long time and painful. Patients don't like it. Okay, so at this point, treatment, you have two approaches. One is that patient, let's say, who is a myasthenia gravis, pure only ocular myasthenia gravis. You basically give person mestinon. You don't give IVIG, plasma exchange, anything like that. But if the person who has generalized myasthenia gravis, okay, the first treatment is this mestinon. If the person is not doing well and still having problem, then you start with the, you know, like a steroid, and you start a steroid in the hospital. Okay, don't do it at outpatient, high dosage, because they get worse. And then you do other immunosuppressive compound. If the person not responding, and the immunosuppressive compound we use is mycophenolate, okay, Cellcept. That's what my favorite, Cellcept. And you can decrease the, you know, the steroid and continue the immunosuppressive. If the person is not doing well, then you can use IVIG. Person who has myasthenic crisis, you use IVIG or plasma exchange, they both are equally good. So here the treatment I had mentioned to you earlier. Okay, you do the thymectomy for thymoma. Then you do other like a mycophenolate, you can give other azathioprine. It takes longer time. And then you also can use rituximab, particularly for, you know, like a rituximab you use in patients with the myasthenia gravis due to the MuSK antibodies, MuSK, okay, rare. So here are the things, complement activation. I talked to you, and we will talk to you more. These are still the same thing. Acetylcholinesterase inhibitor, generalized, you have, you know, like isostigmine we don't normally use. So anyway, but the cholinesterase inhibitor, I already talked to you, mestinon, is for ocular myasthenia, generalized myasthenia gravis. Steroid, as I already mentioned to you, you could, if you, normally we don't use initially with ocular myasthenia gravis. If the patient is not doing well and having side effect with mestinon, then you can use prednisone. Okay, so other immunosuppressive compounds I mentioned to you earlier, mycophenolate, azathioprine, and all others here, methotrexate. We don't use it, as I said to you, that I normally use mycophenolate, steroid, and then IVIG, azathioprine, okay? It takes a long time. Plasmapheresis and IVIG are the same way, but plasmapheresis is more expensive. IVIG, and that too for the myasthenic crisis. Or you give somebody who is not responding to cyclosporin, I mean, to mycophenolate. You can use, like IVIG. Okay, IVIG. And then you also can use rituximab. I don't like rituximab. I have not had a very good experience, except MuSK-associated myasthenia gravis. I do use rituximab. Not very useful in generalized myasthenia gravis. Thymectomy, 8 to 55% of the age group, they can perform a long-term benefit. So in a person, young patient for sure. Young patient has myasthenia gravis proven. We do, like start with mestinon and maybe steroid and maybe others, but then we do thymectomy early and both. An older patient for sure, those who are not responding. Okay, and thymectomy has been very helpful. Okay, in many age groups. Azathioprine, I don't really use. Mycophenolate, yes, we use. The only thing is that when you use mycophenolate, you ask the patient, usually the female patient, you have to get signed up because it's got teratogenicity with mycophenolate, but it's a good drug. Okay, so this one we have talked about it. Okay, various kind of compounds, and this is something which we're going to tell you: complement activation, eculizumab. This compound, which is called Solaris, and Solaris has made my life very, very good because I have a lot of patients who used to come myasthenic crisis every month, couple of times. And this particular compound, which is eculizumab, is a recombinant humanized monoclonal antibody that binds to the C5 complement protein and was approved in 2017. I had total 5 patients with myasthenic crisis. They're not coming any more crisis since I started eculizumab. Okay, so that's again mechanism of action, immune complex C3 to C5, and basically what it is that you do have like using Solaris, which it blocks over here, and these patients they get so better. Eculizumab after age 18, and only time when you use eculizumab, they have documented failure to corticosteroid and other therapeutic agents. They have also had thymectomy, not doing well, and failure of CellCept, rituximab, or Humira. And these patients, Solaris, and I'll tell you more. So Solaris we use initially, you use, like 800 milligram weekly. Then after 2 weeks, you go every 2 weeks, 1200 milligram. And you continue that IV till end. And so we're using new compound, which is called Alexion 1 to 10, and we are under trial. The most important thing of this is the half-life is longer, and basically it could be given every 8 weeks to 12 weeks. Okay, 8 weeks instead of every 2 weeks. So that's important. It's very good because these patients get better than Solaris. Okay, or eculizumab, and hopefully we will know more about it in a year time. We have many cases, and other people have too. Rituximab, as I mentioned to you, is good in MuSK antibodies, but it can be used in others too. But I don't use it. Okay, there are a lot of other compounds. Okay, those who are coming up now. Okay, and you have this depleted cells, CD20 depletion, and again that's rituximab. You have Anthera, which is another one, and then they all have been, again, these are under trial, and we don't have, and then here too, the same thing, but then none of them are this Bicluzumab, which is in phase 2 trial. Okay, but nothing is known yet except Solaris and Bicluzumab, which we are under trial right now. So coming back to the myasthenia gravis, I already talked to you about different types of myasthenia gravis, the treatment, symptomatic treatment, is basically, mestinine or pyrostigmine, okay? And you can give every 4 hours, 60 milligram, 6 hours, 3 hours, and then you have a 180 milligram, which you give in the night. I use first this one for ocular myasthenia gravis and generalized myasthenia gravis initially. And then other immunotherapy I mentioned to you earlier, prednisone, start with the prednisone. Okay, I don't go for 5 to 6 months. It takes 2 or 3 weeks to help. And I go to 2 months up. And then at the same time, I add on to this medicine, mycophenolate. Okay. A person who has myasthenic crisis, you have this plasma exchange or IVIG. Both of them are equally good. I use IVIG, okay? And thymectomy, of course, is done in most of the cases. Now, these are the congenital myasthenic syndrome, have nothing to do with immune mediation. And these patients are different and they have many types. It's called congenital myasthenic syndromes. And they are both presynaptic, synaptic, and postsynaptic. And there are many of them. These are usually seen in pediatric age group, okay? And they have fast channel myasthenic syndrome. They have congenital myasthenic syndrome, beta subunit mutation, reduced expression of acetylcholine receptors, and severe weakness. We don't really, see a lot of them over here. Then you also have congenital raspin. Remember I showed you reduced expression, the raspin. You also congenital myasthenic syndrome resembling Lambert-Eaton. We see this. And then there are low affinity fast channel syndrome. These are all very rare, but you need to be aware of them. They don't respond to the treatment, and the chest X-ray, etc., are not very good. Fast channel, and then you have reduced expression of beta subunits, and then congenital with the delta subunits I mentioned to you earlier, and raspin, and the reduced expression. And there are many other familiar form of postsynaptic myasthenic syndrome. Okay, so that's kind of, and we don't see too many of them. Next thing, COVID. I'm going to talk to you guys about neurology and COVID-19. COVID can cause severe respiratory syndrome and affect the respiratory symptoms, pneumonia, fever, cough, etc. Neurological manifestation, you have a headache, you can have a seizure, you can have strokes, and then you have systemic vascular dissemination. And these people, they have, remember they have smell problem, and that's due to the viruses that go into the cribriform plate of ethmoid and go to the olfactory nerve and cause a problem. So back again, here are the neurological stuff. Many things which you can have: confusion, anosmia, etc. But COVID-19 an effect on myasthenia gravis and LEMS treatment. No data is available, but patients have had myasthenic patients with COVID, and basically you can continue to be giving their immunosuppressive compound. You don't have to stop. Remember that. Okay, treatment guidelines, generally myasthenic and LEMS should continue their current treatment, and seizing or altering immunosuppressive therapy increase likelihood of contracting. So you don't do anything else. No evidence that using 3,4-dipyrimidine or complement inhibitor I just showed to you that should be continued. Eculizumab can be given. They don't have to stop it. B cells like mycophenolate can also be given. There's no reason not to do that. And then other one, these patients, they have COVID-19, they have a myopathy, and particularly critical illness myopathy have been described. And you don't need to, so here something about myasthenic patients, those who have critical illness, and you see fibrillation, positive shock wave. So anyway, that's kind of given to you guys about COVID and neurological syndrome and neuromuscular syndrome. So I am kind of done. I'm going to talk to you, we'll summarize the whole thing. Neuromuscular junction is an important part of motor activities. It consists of three parts: presynaptic, synaptic, and postsynaptic. There are various processes in acetylcholine receptors activities, which I share with you. Okay, there are various type disorders: presynaptic, synaptic, and postsynaptic. They can be inherited and acquired. Myasthenia gravis is the most important neuromuscular junction disorder in the world, all over. And a lot of work has been done with myasthenia gravis, both like diagnostic test, treatment, and hopefully we'll be continue to be doing it. We have many cases which we are doing it. So next thing is, I've given you a little bit history about COVID and neuromuscular junction. With this, I am done. Question, anybody?
Okay, thank you, dear Professor Mishra, for first your time, valuable time, then for this heavy meal of a lot of for informations about these topics. So first, I need to welcome for Professor Dr. Lami Afifi, one of the professor of neuromuscular of the neurophysiology, Qasr Al Aini. So if you need dear Dr. Lami and dear Dr. Professor Amira Darwish to join with your voice, no problem. Just click on raise hand, and I can do this, or as you need, just to put your questions. Okay. So first question there, Dr. Mishra.
Yes.
Yeah. First question from Dr. Lamia. Please explain the facial features of musk myasthenia gravis.
Okay. Again, this is I think 3 to 5% of myasthenic patients, those who are due to musk. And I have showed you where the musk is located on the top of acetylcholine receptors antibodies. Musk seen more in the females. Understand that, more in the female. European ancestry, you could have other places too. And these patients, they have a facial. I showed you the picture of the face. It's called snarl face. Their faces look like this. And these patients, they don't respond well to the treatment. They don't respond well to mestinon, not to acetylcholine receptors antibody. And also CellCept, etc. They do respond to rituximab. So we use the patient with the rituximab once we have proven, but musk is not very common, but you need to be aware of it.
Okay, I can put my question. First, in congenital myasthenic syndrome, if referred for electrophysiology, the repetitive nerve stimulation is normal.
No, it's not. Usually it's normal, but you may have, there are many types, okay? There's congenital myasthenic syndrome. There was one I showed to you earlier as a limb girdle type of oculo. And those patients, they have myopathic pictures. And that case was described from Iraq many, many years ago.
Yeah.
Okay. But then you have, there's many ways of doing the test. And usually,
single fiber.
Yeah, you can do the single fiber EMG on some of those cases. Yes.
That's great. So which muscles can you start with in single fiber EMG?
But the most common is I talk to you guys using, extensor indicis or extensor proprius. This is on forearm muscle, which is the major, those two muscles. But you can do anything. You can do on the face. You can do on the other muscle. But these two muscles, okay, are more important, extensor indicis and extensor proprius. The problem is that these people have to hold their finger like up for an hour, and it becomes really, really painful. Sometimes patients, they quit in between, say, I don't want to do it. As I said, I don't really start with single fiber. I normally use repetitive nerve stimulation and the clinical. If that's a positive, and I don't go to single, but we do for the teaching purposes, we do single fiber EMG. And those are the two muscles I use. And I showed to you guys earlier in Egypt.
There is a question from Dr. Farouk Mateen, where there is, why there is must decrement effect in fourth repetitive he mean the waveform when we do the train of 5 in repetitive nerve stimulation.
So normally we do 3 to 5 initially. And first I do the ulnar nerve. I do is to record from ADM muscle, first. And then if that's a positive, and it's very much clinical, we really, that's the end. But if the person not sure there, then we do the accessory. Now, accessory is recording from the trapezius, and that's a positive, and that's the end. Sometimes we do use the facial. Now, facial we don't use 5, we use 3. Okay, 3, and you find decremental response there. And so those are the 2 I use. I do facial rarely, very rarely, painful.
Yeah, he asked why we see the decrement in the first one.
The first one, because remember I showed you that acetylcholine receptors are decreased as a postsynaptic disorder. So therefore they are the less, like when we give them mestinon, remember that the acetylcholinesterase kills that, the mestinon acetylcholinesterase, and therefore there's a more acetylcholine is available at the postsynaptic junction. So basically stimulation, if you do the first time, you find there's a decrease, means there's a less acetylcholine receptors. But when I ask the person to exercise, you recruit more acetylcholine receptors antibodies, and you correct the decrement. And then if you wait for 3 minutes, then person becomes decremental. So 1, 2, 3, those are the 3 which we normally use.
Okay.
All right, because there's a less acetylcholine receptor is decreased.
Yeah. Again, question from Dr. Lamia. Why do you advise against use of facial nerve for repetitive nerve stimulation?
Number 1, it's painful. Okay.
Painful, yeah.
Number 2, now if you have done from the distal, there's no reason to do the face. Okay. Now, sometimes we do that in ocular myasthenia gravis, facial, ocular myasthenia gravis, but still people, they complain. But good thing is about only 3 times, and you record from nasalis muscle, you stimulate here as the stylocardomastoid or the stylomastoid foramina, stimulate the nerve there. And we do, but it's a painful. A lot of times the people say, no, doctor, don't do it. But if we can get it,
it's most easily to catch the decrement in facial. Yeah.
Yeah, it
Okay.
can be. But then if a person has generalized myasthenia gravis, facial stimulation may be normal.
Yeah. In neonatal myasthenia gravis, neonatal myasthenia.
Yes.
How can we differentiate electrophysiologically between neonatal myasthenia gravis and anterior horny cell disorders like spinal muscle atrophy?
No, two things. See, person with neonatal myasthenia gravis, that mother had myasthenia gravis, and a person is born as a floppy baby, remember. And then you see there is ptosis, there is a difficulty in swallowing of face, whereas the SMA, as a floppy baby, they can't do anything, and they do have tongue fasciculation. If you look at, but they don't have lots of, like others, lots of, and there's no weakness. And the patient, they get better after giving, tensilon right away. You give the IV tensilon in patient with neonatal myasthenia gravis, they become 100% normal. But in patient with SMA, nothing happens.
Yeah. There is a question again from Dr. Mateen. Is there any other method in neurophysiology in diagnosed Lambert-Eaton if the patient does not allow the fast frequency, he does in repetitive nerve stimulation?
So the point is that, again, if you got, like Lambert-Eaton syndrome clinically, remember I talked to you clinically, these patients either both, they're non-cancerous and cancerous. they have distal involvement. Their weakness is more distal, weight loss, as well as decreased reflexes, okay, contrary to other myasthenia gravis. So that's again, like in Lambert-Eaton syndrome, what you do clinically, and you do that, like the blood test. What I have, like potassium channel, I mentioned to you, and you can send that blood test, and you will find abnormalities in D4, like antibodies in patients with Lambert-Eaton syndrome.
Yeah. Any questions from the attendees? So I don't see the other questions in Facebook page. So I think this is the end for this presentation with an eminent one, Professor Dr. Mishra. Thank you for your valuable time.
All right, you guys. So when are we doing it? When are we doing it in Morocco?
Yeah.
I'm kidding, you guys. Okay, we'll do that sometime in remember, in Egypt and other countries. Remember, that's your plan.
Thank you.
All right.
Okay.
With this, bye, you guys. Again, everybody.
Okay, bye, dear Professor.
Bye, everybody.
Okay, bye. Okay, dear attendees, I think we have a lot of webinars. Please follow us on our pages. We have a lot of neuromuscular ultrasonography. Also, we have a very interesting talk about the electrodiagnosis for brachial plexopathy, as well as the neuromuscular sonography. We compare what about the can add of the value for neuromuscular ultrasound. So join us in 27 August. See you. Bye, dear Dr. Mishra. See you.
Okay, bye. Hey, you want to see? Hey, Najam. Hey, look at my wife.
Hi.
She said that you shaved your head.
Yeah.